All right, everyone, thank you so much and welcome to the second part of our Crazy Cornea series, where we will be talking about addressing the neurotrophic and neuropathic surface with Dr. Walt Whitley. And I'm filling in for Dr. Elise Kramer. My name is Dr. Stephanie Wu. I will be your host for this evening, and I am the founder of Wu University. It is now my pleasure to introduce our speaker for tonight, Dr. Walt Whitley. Dr. Whitley is the Director of Professional Relations and Education at the Virginia Eye Consultants at Norfolk, Virginia, and the Regional Medical Director for Eye Care Partners, LLC. He is an expert not only on dry eye, but glaucoma, which is amazing because a lot of times people that specialize in anterior surface disease don't really lecture about posterior, and we have been very lucky to have Dr. Whitley on Wu U events for a variety of topics. Last one he gave was on visual fields, which was amazing. And as you can see, he has incredible accolades. He's won tons of awards, such as the 2012 Young Optometrist of the Year, the 2015 Legislative Key Person of the Year, and 2020 Optometrist of the Year. Walt, welcome back to Wu U.
Hey, thank you so much, Stephanie, and thank you to the Wu University team for putting these great programs on together. And so we know that when it comes to education, things are changing. We have to adapt. And we know that virtual and online CE is definitely a way that we can gain this information, help our patients, and give them both the visual and medical eye care that they need and deserve. Tonight, I'm going to talk about neurotrophic and neuropathic corneas. And I do want to make sure that you see my disclosures. I work with a variety of companies. I do consult for Dompe as well, and they are a sponsor here. But I did mitigate any of the slides, or I'm pretty much just telling like it is, just like we see within clinic on a day in and day out basis. But working with various companies, one of the things that does allow me is to share a lot of the information. What's available now, what are the needs in the future, what's in the pipeline. And so when we're talking about both of these conditions, and we'll go through various cases, we'll be able to see how it impacts our patients now, but also what are some of the needs and treatments we may have in the future. And so that's our title there, ocular surface, both neurotrophic and neuropathic ocular surface. So a little bit about my practice. I do practice at Virginia Eye Consultants, and we are a tertiary referral care practice. I've been here for about over 13 years now. And within the practice, we have 4 cornea specialists who I've learned a lot from over the years. John Shepard, Liz Yu, Steve Scoper, and Albert Chung. And they've helped me with many of these cases in the past, or some of the complex cases, especially when it comes to neurotrophic keratitis, stage 2 and stage 3, which we're going to go into. But what we're going to do is we're going to start this off with a case, and feel free to ask questions throughout and put things in the chat box. And then Stephanie, she'll help go through those and call me out whenever a question comes up. But we're going to have time at the end as well. And so here's our patient. So we have a 46-year-old white female new patient referred from one of the ODs in the area for a dry evaluation. And just looking at the history, blurry vision, which fluctuates, constant, significant, light sensitive, found that only drops that provide relief are steroids. And we know many patients love steroids, and it's an effective treatment. We just have to use it judiciously. But of course, like many other medications, the brand is not covered by the insurance. Eyes are so dry, they feel like the lids are sticking to the surface. Uses artificial tears, but did not tried many, but didn't find relief. But of course, she wants new glasses as well. And she's had punctal plugs in the past, but they've fallen out. And so the OD said, hey, come take a look at, have that team take a look at you, maybe consider a punctal cautery as well. The most recent plug she had was a silicone plug, and we know sometimes that can cause irritation. But as I mentioned, the only thing that works for her is going to be the loteprednol, 0.5%. And so this is the initial Lotemax formulation. But she has tried cyclosporin and lifitegrast in the past. Looking at her history, the medication she's on, And so, what are some of the additional questions we want to ask this patient? Well, tell me more about your vision. We know blurry vision is one of the most common complaints that patient comes to our clinic, but is it always blurry? If it's always blurry, it's refractive error, cataracts, maybe AMD. But if it changes or fluctuates, then we know it's an unstable tear film and a poor surface. And what can we do to address that? She's tried the various drops. Steroids do provide relief. And so what is going to be the best treatment for her, just not short term, but long term? And she's tried other, more of the chronic medications that are available to her. So looking at the exam, her vision was still, she complains of blurry vision, but 2020 and 2025, which really isn't that bad. Looking at the slit lamp, telangiectasia, cloudy secretions. We always have to look at the function of the meibomian glands. She did have some inflammation. She does complain about allergies, seasonal allergies. But looking at the surface, her tear film breakup time was below 10, which you can see there. She didn't have any staining on the cornea. Did the inflammation test and had mild positive on the right. And a positive result on the inflammatory test is anything over 40 nanograms per milliliter. Anything above that will give a pink. If it's a really dark pink, then we know the patient does have more severe inflammation. But looking at the osmolarity or the salt concentration of the tears, that is in the normal levels. And so if we take a look at the meibography, and so you can see the right eye and the left eye, maybe lost 25% in the right, maybe 30% in the left eye, but she's complaining about fluctuating vision. And so what are some of the things that can help her, but also the pain? I mean, she was one of those patients that came in as just very, very symptomatic, but not very happy as well. And so, what are some of the other factors we have to consider, whether it's psychological, whether it's, how they feel, mental capacity. And so some of the things we want to think of. So, what are some of the next steps and additional tests and perhaps a diagnosis? Well, that's why we're tuning into this lecture, so we can break through this and think about what are some of the options. To start off, we have to look at the corneal anatomy, which we all know is most richly innervated surface within the body, densely supplied by the sensory and autonomic nerve fibers. And there's 7,000 nerves or nociceptors within a millimeter squared on that corneal surface, so densely innervated. We know that these sensory nerves come from the ophthalmic division of the trigeminal nerve, and they possess both sensory and efferent functions, and they can be stimulated by mechanical, thermal, chemical stimulation, which can cause the pain. Looking at the pain receptors, we know within the cornea, there are the sharp immediate pain A delta fibers, but also within the subbasal layers of the cornea, they do have the unmyelinated C fibers that lead to this inflammation when it's triggered. And so these receptors lay dormant until stimulated and are often sensitized by inflammation. So inflammation does play a role in the ocular surface disease and both NK and neuropathic corneal pain. So the nociceptors, these are distributed without the tissues in the body and mentioned stimulated by heat, energy, trauma, emotion, and chemicals. And this is pretty much just simplifying it as much as possible. But within the tissues, you can see from number one, the painful stimuli, maybe they touched a hot stove, or for the eye, something triggered the irritation in the eye. Then it goes to the dorsal horn of the spinal cord, goes to the brain through whatever receptor that triggered the pain, that any previous thoughts, feelings, or may change and amplify or minify that pain response. And then it's going to go back into the tissues to render its effect. But let's take a look at some of the studies that are out there. And so this was published several years ago, but looking at the relationship between the subbasal nerve morphology and corneal sensation in ocular surface disease. And you can see that corneal sensitivity was significantly decreased in dry eye and glaucoma patients compared with controls. And we know the density and number of the subbasal corneal nerves were also significantly decreased. And we know why, because of preservatives. And we know what the effect of chronic preservatives can have on the ocular surface. It's essentially a detergent that can accumulate within the corneal epithelium. It does impact, and studies show that it interferes with the mucin layer, the goblet layer, and so it does disrupt that tear film and and causes the damage and the sensations patients have. I'm not going to go too far into refractive surgery. There's studies. Pasquale did a study looking at the hinge position. And so in his study, the right eye had a superior hinge, the left eye had a nasal hinge, and was trying to determine, did hinge position, and we know that there's various distribution of the nerves, but the hinge position had no effect on corneal sensation. It was reduced in both arms, both nasal and superior, but something that we do know that happens, but something that we have to monitor and address, not just short-term or long-term. As for transient light sensitivity syndrome, this is something we saw with the earlier femtosecond lasers for LASIK, but not seen with more the newer lasers. So that's all I'm going to mention about that. So let's move over to dry eye, because when we look at ocular surface disease, it is a spectrum. And so when we look at neurotrophic or neuropathic, many of the symptoms are going to be similar. But if we look at the TFOS DUS2, the definition itself, and look at those callouts: loss of homeostasis, ocular symptoms. And so those are the easy ones. And so whether you're asking questions routinely for whatever the reason of the visit is, whether it's for vision, whether it's for medical, those are easy. And so just if patients are complaining, making sure we're looking for signs and following up on that and treating accordingly. Tear film stability or instability, what is that tear film breakup time? And many of the cases or patients we all see, when's the last time you saw a tear film breakup time over 10? We're really not seeing that these days, just from all the risk factors and just from life itself. Hyperosmolarity, so increased salt concentration of the tears. Inflammation, right? This is sequelae of the evaporative stress when we look at MGD. But inflammation does play a role. And when it comes to neuropathic corneal pain, the peripheral sensitization, where it lowers the threshold for any response, so any insult to the cornea, patients can have an exaggerated response, where in the neuropathic cornea, those are faulty nerves. And then so they're abnormally firing, and that's why you're having such a significant pain response or symptom patients that do have. And that leads to the neurosensory abnormalities that have been found. And there's still a lot more that we're looking into that. And research is going to tell us more, especially within the next TFOS report that comes out. So let's take a look at the corneal nerve structure and function compared with non-Sjogren's dry eye versus controls. And we know the mean corneal sensitivity was significantly lower in the dry eye patient. We know that dry eye, yes, we have our dry eye flares, but with chronic dry eye, chronic inflammation, this does decrease the sensitivity of the nerves. And so what can we do to rehabilitate those nerves? So what's happening in dry eye? The sensory nerves may adapt to the irritation by decreasing the frequency and intensity of the action potentials. But with time, this elevates the pain threshold. Stronger stimuli is needed to evoke the corneal sensation. But hypoesthesia plays a role in the pathogenesis of tear deficiency, because if the nerves not have that normal feedback, then that's going to lead to decreased tear production. So here's a patient that we've all seen. And so this is a patient we may have thrown every dry eye therapy on, and nothing's getting better. So this is that diffuse staining or dense SPK that we may see throughout the cornea. Many of our patients, we have tried the various cyclosporins, lifitegrast, the immunomodulators there, or any anti-inflammatories. But if it's not getting any better, let's say the patient's been on it for a couple months, we need to take a step back and take a look at the corneal surface. We need to test the nerves. And just to be upfront with you, that's one of the call outs or the things that take home, is to think about corneal sensitivity and testing for corneal sensitivity. So that's something that I've incorporated into any of my dry eye evaluations. And so we'll go into that testing. So we're going to start off with neurotrophic keratitis. And so what is NK? Well, it's decreased sensation, decrease or no pain. And so here's a patient with a stage 2 neurotrophic keratitis. And so this is ulcerative. It is degenerative corneal disease. damage to the trigeminal nerve, so you're not getting that feedback loop, breakdown of the corneal epithelium, and persistent epithelial defect. And for stage 2, that can progress to stage 3, that can lead to stromal perforation and melting. And so that's where it's always good to have a photo friend right next door. We always have our referral sources and our surgeons that we work closely with. And so, hey, feel free to put in the chat. I'm curious, how many cases of NK do you see a week, or how many could we have potentially missed in a week if we're not testing for corneal sensitivity? And I'm going to say each day I see at least 1 or 2 patients a day. And but of course, I'm in a specialty clinic. But if we're not looking, we're never going to be able to identify these patients. And so, once again, challenging you to test for corneal sensitivity, because there are ways that we can help our patients to help improve that surface, improve those nerves, and improve their outcomes. So what is a rare disease? NK is classified as one, and it's fewer than 65,000, which is affected in the US. So roughly less than 5 individuals in every 10,000. But looking at the prevalence, it is difficult to determine. The best data, as you can see on the right, is extrapolated from the most common conditions associated with it, whether it's herpes keratitis, herpes or simplex or zoster, or any post-surgical nerve damage the patient may have. Differential diagnosis, loss of corneal sensation. We will only know this if we're testing for it. However, we do have those patients that we often see, those patients with diabetes that have a poor ocular surface, significant staining, but we ask them, how do your eyes feel? Oh, my eyes feel fine, and they're having no issues with it. But this is something we need to look for. When it comes to dry eye, studies show that 54% of patients with diabetes do have dry eye disease. We do know that diabetes affects the peripheral nerve endings, including the cornea. And so that's why it's important for us to look, because the patient may not have that sensation. The differential, well, neuropathic corneal pain or keratoneuralgia. So that's the opposite, which is the pain without stain. So that was that patient, the first patient that I presented, that everything looked good, light sensitive, pain. I didn't put her speed score, but it was well over 20. And we know that speed score, the highest score you can have is a 28. But this pain is a response to minimal or even no insult. So patients are just in chronic pain. There are diseases with overlapping features of NK and can lead to NK if the corneal sensation is affected, and you can see those there down below. So going back to the feedback loop, we know that the cornea is once again the most sensitive and innervated tissues within the body, and any disruption can delay the healing of the corneal epithelial cells. It can delay the regeneration or survival, and can cause things to get worse. And that leads to our stage 2 and stage 3 neurotrophic keratitis or corneal ulcers or even perforations that may occur. So within the corneal nerves, this does maintain the corneal integrity. It does serve as a protective function, secretes the nerve growth factors, helps with epithelial cell proliferation, migration, and adhesion. But if this feedback loop is damaged, that leads to more breakdown and poor healing of the ocular surface. So what are some of the etiologies? And I mentioned herpes several times, or simplex or zoster. Diabetes, we just talked about. Contact lenses. There's numerous reports of contact lenses being associated with neurotrophic keratitis, but also any trigeminal nerve palsies that can affect it. So let's get into a case for neurotrophic keratitis. An 84-year-old African-American female presents for 3 to 4 month check. I put no touch because if I don't put that, my technician's going to check the pressure. And we know that anytime you put anesthetic in the eye, that's going to disrupt the tear film. So we're not going to have good, accurate results when we're looking at staining. We're looking at tear film breakup time. And so I always tell our patients to hold off. If I needed to check, let's say they're on a steroid, I need to check the pressure. I always make sure I do that last. I'll do that myself. They do the MMP9 testing, so I know whether or not there's inflammation present. But you can see history of dry eye, open angle glaucoma. The left eye more than the right eye has itching, uses a cyclosporin and artificial tears. Last time I saw her, and I've been seeing her for a while, and so she's never been a steroid responder. Anytime you prescribe a steroid, always check the pressure but always check the nerve, because anyone who's going to be a steroid responder is typically going to be a glaucoma patient. But she was never a responder. And whenever I prescribe it, let's say this fluoromethalone, I typically only do one prescription. I don't have any refills, except if it's one of the newer formulations of loteprednol, the on-label version. I would give the patient at least 1 or 2 refills of that. But how compliant are your patients? I'd love to hear, because mine aren't always so compliant. And so not using the ointment that I prescribed for her, or the heat mask. And we know with any ocular surface condition, it's important that patients are following our recommended treatment. So just looking at the history and just thinking about NK, look at her history. Everything contributes to it. History of dry eye, history of stromal keratitis from herpes, history of inflammation or scleritis. She does have open-angle glaucoma, and she was on prostaglandin for long term. However, we did the cataract surgery and did a stent in there to lower the pressures. We've tried the amniotic membranes a couple times. We've done punctal cautery, and so those are things that we always want to consider when it's leading up to our diagnosis. Diabetes, we already mentioned. Seasonal allergies, making sure we're asking our patients, tell me about your symptoms. If your symptoms are just itch of the eye, well, let's put you on site-specific therapy versus using the oral cetirizine that may cause more dryness within the eye and throughout the body. So looking at the clinical exam, we always have to take care of the lids or look at them, because if we're missing blepharitis, we're missing MGD, we're going to miss the boat, because we've all had that patient, we put on whatever dry eye medication, and they come back still symptomatic, and it's because we've ignored the lids. Looking at the surface, 2+ inferior SPK, dense SPK in the left eye, 1+ corneal edema. And I checked the pressure after I looked at the staining and everything else. You can see the inflammatory test did show some inflammation. But what else should we add? What other testing are you adding to your dry evaluations? And as I mentioned, doing corneal sensitivity, which I'll show you shortly, but also look at that right eye. 2+ inferior SPK, we always need to look for nocturnal light ophthalmos. And so using your transilluminator and do the core Blackie light test, just put the transilluminator on the upper lid, look to see if you see any illumination underneath the lid margin, the lash margin. And if you do, we treat it either with the ointments, or what I've been using and having great success with is a hypoallergenic lid tape. So tape tarsorrhaphy, it just came to market a few months ago, or about a year ago, actually, Sleep Tight, Sleep Right, and have had great success with that. Because if you're missing the nocturnal light ophthalmos, you can put anything you want all day long, but it's still going to be symptomatic. But testing corneal sensitivity, right eye normal, left eye reduced. So we already identified what the patient's issue may be. And so, do you test for corneal sensitivity? I already asked, and how do you test? Is it central? Are you looking at all the quadrants? The main thing is just to test first. And as you get more experience with it, then, within our cornea clinic, we're testing all quadrants, because let's say the patient has a history of herpes, it's not herpes all throughout the cornea, but it's going to be more sectorial oftentimes. And so we're going to find areas that are going to have reduced sensitivity, maybe inferior versus superior for those patients. Corneal sensation, this will be important, especially if you have to take a test later. But greatest of the corneal central cornea, it drops rapidly as distance increases from the limbus, and it does fall with increasing age. It is more sensitive in the temporal limbus than the inferior limbus, and mentioned that with diabetes, there is a reduction in corneal sensation. And so you can take your cotton wisp here, and so just making a fine point. You can take a tissue. If you have a Cochet-Bonnet aesthesiometer, you can do that. That's typically used in clinical research, or even using something like dental floss and just touching. Is it normal? Is it reduced? Is it absent? Or do they have, if they're having hyper response and more sensitive to it, you just document that, but reduced or absent, you already have your diagnosis of NK. Probably not the best pictures here, but she did have NK, and so the staining did not come out as well. You can see it did have meibomian gland issues too. But looking at the classification, So the stage 1, that's that blue picture with that diffuse staining I showed earlier, characterized by hyperplasia or irregularity of epithelium. So this is that chronic recalcitrant dry eye that we've been seeing. Stage 2 is a persistent epithelial defect without stromal thinning. And then stage 3 is going to be the stromal involvement that leads to the corneal ulcer and melting. And here's just a few pictures showing the difference. Here, typically in stage 2, you have the oval shaped ulcer that you see there. And then stage 3, you'll have the corneal ulcer, can lead to the melting as well as the perforation. And so with neurotrophic keratitis, we have impaired trigeminal corneal innervation. And so you can see the sequelae, it's not able to heal itself because everything's been damaged. You're not having enough tears. The epithelial cells aren't able to regenerate. You're getting an increase in stromal edema. And so this is something that needs to be addressed. And so by applying nerve growth factors, this helps maintain the corneal integrity by several different mechanisms. Here you can see, we'll start on the top. The nerve growth factor plays a role in the nerve function and stimulates regeneration and survival of the sensory nerves. The bottom right stimulates proliferation, differentiation, and survival of the corneal epithelial cells. And on the left, it binds the receptors on the lacrimal glands and promotes sensory-mediated reflex tearing. And so that's why we need something that can help regenerate those nerves. So if you have a patient with neurotrophic keratitis, what are the treatments? And if you just look by severity-based therapy, you can see the various levels. Stage 1, preservative-free tears, punctal occlusion. You can use a hydrogel contact lens, a large diameter. Consider Synergimin, which we'll go into shortly. Serum Tears, autologous serum is another thing we can utilize. And then as it progresses, and hopefully it doesn't progress, we have our other therapies, including scleral lenses, amniotic membranes, maybe Botox or a tarsorrhaphy. And then if it's melting or perforated, then we'll need our keratoplasty or neurotization procedure, which I'll show you shortly. So serum tears, I don't have any experience here within our area. We don't have a lab that would do it. We do have to send our patients a couple hours away to Richmond, Virginia, to get the blood drawn and get this set up. I do know there's a company, and I'm just talking out loud. You can read the studies. It works. So that's why I have these studies up here. But there are companies such as Vital Tears, which we recently signed up on within our practice. And so looking forward to utilizing this. But you can see the benefits that it has on patients with neurotrophic keratitis on the various studies there. Success serum alone ranges from 71 to 100% within 90 days. And this will all be in your notes. The amniotic membranes, whether it's cryopreserved or whether it's the dry membrane, you can see how it healed the neurotrophic corneal ulcers with conventional therapy versus the membrane. Healing rates were similar, a little higher with the amniotic membrane, but the amniotic membrane was also equivalent to autologous serum, about 70% with the autologous serum group and about 73% with the amniotic membrane group. Scleral lenses, I love them. I've only seen one in my life, but I do refer them out, and we have a great network of optometrists that do this. And so this is something that can be utilized for patients with neurotrophic keratitis. But corneal neurotization, so this is a surgery, and there's several ways that this can be done. You can take the sural nerve from the calf and then just use it to help provide nerve supply to the cornea itself. Actually, one of our friends, Dr. Basecker out of Meridian, Idaho, he did help get me a video, which I'm going to show. So if you really want to wake up now or don't want to see an extreme video, well, here it is anyway. And so this is from Dr. Len Gold from the Len Gold Institute of Plastic Surgery in Meridian, Idaho. And so you can see the subtitles here. But this is a way for patients that need surgical intervention for neurotrophic keratitis, where essentially they're going to do in the surgery. This is an allograft, and so this is from a donor nerve, but you can use it from the contralateral supratrochlear nerve, or as I mentioned, you can use it from the sural nerve, but different ways to do it. There's only a handful of surgeons that do this throughout the country. A lot of times it's going to be academic centers, but essentially just harvesting that nerve and just getting down to the layers. You're going to remove any of the adipose tissue or the fibrin surrounding the nerve. And so here you're going to do the blepharotomy here just to create a canal. He's going to help put that nerve into the conjunctival space. And so here's going to dissect the conjunctiva, dissect the subtenons, and then just doing the tunneling procedures, moving those nerves to the cornea limbus, and then suturing on onto that area. And so I've not co-managed any of these, but this is something that is available, and you may have a surgeon in your area. This is followed by a tarsorrhaphy. Once that surface heals up, then they can remove those sutures as well. So thank you, Dr. Besecker, for sending me that video. Thank you to Dr. Len Gold. So as I mentioned, that was intense, but it is a surgery that is available, but I didn't recommend that for my patient. I told her to use a cyclosporin twice a day, keeping the heat mask. I did stop the oral allergy drop. You know, if patients have ocular allergies and chronic surface issues, I've been going to preservative-free aloe, so ketotifen, so less preservatives on the eye, and I've had great success with that. I did order Synedrimin and told the patient to call once the meds came in, schedule for a follow-up in 3 to 4 months for the glaucoma. But typically, you know, when you order the medication, there's an application. The medication is supplied by Dompe and Dompe Cares Connect. They work with the patient's insurance. Typically, patients pay anywhere between 0 to 30 on average. I had one patient that paid $100, but so they try to get it covered by the insurance. If it doesn't, there's a foundation that's going to help subsidize the rest. And so this is something that patients can utilize and has been a life changer for many patients. It was approved a few years ago. So if you haven't had a chance to utilize it, I do challenge you or recommend for you to use it, because you're going to see the benefits that it has on our patients on those surface. And so those challenging corneas that you've had, this is going to make a difference for them. And if you look at the clinical studies, and you can see them here, but up to 72% of patients achieve complete corneal healing, and 80% of healed patients were recurrence-free after 1 year. And so this is something that you're going to hear more and more successful stories of how it benefited our patients. And my patient that I use this on, she did improve. The surface did improve on both sides, with the nocturnal lag ophthalmos on the right eye she had, and the neurotrophic keratitis on the left. And so something that's been beneficial for our patient. Another patient here. So this is a patient I saw just a few months ago. And so this patient, you can see in the history, just had surgery, cataract surgery on the right eye, end of July. About a month later, the patient presented with about a 5-6 millimeter corneal abrasion. At that visit, you know, they also stained with rose bengal, looking for any type of herpetic type lesion, and it did stain. So our team put the patient on valacyclovir 500 milligrams 3 times a day. Had the patient on all those drops. Why? Because they had CME, and so you needed the ketorolac, difluprednate, had glaucoma or high pressure, so I had them on the drops. And so, you know, if you see this and this is how it presents to you, you take a look here, vision's horrible. So 20/80, you can still see a large defect even a week later with just a bandaged lens and those drops they were on. It did have mild CME. And so what is the next step? And so going back to the medication here, we have a non-healing epithelial defect the patient may have had, looking at all those preservatives the patient's on, looking at the anti-inflammatories, whether it's a steroid or the non-steroidal, especially the ketorolac, that can delay corneal healing. So what I did is I just stopped those. I stopped the steroids, kept her on the moxifloxacin because of the defect, took her off the timolol brimonidine because we could always treat the pressure, but until we can heal that surface, the patient's still going to have issues. But the other thing that I did is I put the patient, I tried a crown preserved membrane on the patient. But this is that one time you put it in the eye and it's like sticking out a little bit. And so you do a tape tarsorrhaphy to push it, position it back in. Patient goes home and puts the drops in, and then the amniotic membrane fell out. And so she came back. I ended up doing a dry membrane on her, brought her back a week later, and here's what it looked like. And so needed to help heal that ocular surface. She was already on the antivirals, which weren't improving. And so in this case, it was a non-healing cornea. So we had to do something to intervene and improve that surface. And so, those are just a couple treatments for neurotrophic keratitis. There's many future treatments, and they're all going to focus on innervating the corneal epithelium, the corneal nerves, which is the thymosin beta 4, the insulin-like growth factor. We know that there are insulin receptors within the cornea. And so in some rat models and some early studies are showing that it can improve that corneal surface and innervation. For patients of Varenicline, we know that it is approved in the nasal form right now for signs and symptoms of dry eye, but they're also looking at studies in it for NK. And so if you have any questions on those, feel free to put them in the chat box. But then we're going to finish the second half of this lecture going into more of the neuropathic corneal pain. And so here's a patient, a 29-year-old white female that presents for significant dry eye. Eyes are always in pain, burning, gritty, feels like sandpaper. Currently uses Serum Tears 50%, and she wanted to get 75% tears. And so I'm not sure if any of you have prescribed 75% autologous serum. I have not. I called a couple phone friends. I told her I'll call a couple phone friends after this this examination, see what their thoughts. And I don't know anyone that really has done that much. You can do it, but as we know, the higher concentration, the thicker the tears get itself. However, if we're trying to improve those corneal nerves, there's going to be also increase in the nerve growth factor. And so if you can get 75%, could it help? I haven't seen any papers, but something to consider. So ocular history, 8 years of significant dry eye. Why would a 29-year-old have significant dry eye for 8 years? You can see the medications, ADHD meds, also hypothyroid meds, and oxynortriptyline. And so what questions do you want to ask? And so, of course, we're going to ask, well, what have you tried? Well, they've tried everything. And so not to go into every single one of these, but this is why it's so important for us to understand the medications, how they work, how quickly they work, setting those expectations for those patients. Because, for instance, cyclosporin, that's not going to work in a month. The clinical data is up to 6 months. And we know it does take at least 4 to 6 months for that to take full effect. Steroids she's been on, her eyes are painful. Steroids are for pain and inflammation. She said that didn't work. Plugs, Lefitograst, another version of steroids. Tried to use the anti-inflammatory, actually the antibacterial dose of doxycycline. That didn't work. Erythromycin, multiple preservative-free drops. And so this goes on and on. So the autologous serum is the only thing that's been working for her, but she's asking for more. So just, take a step back and think about, what are some of the things that we can do here? So here's a picture of a normal eye. We know what a normal eye looks like. You know what fluorescein staining of a normal eye looks like. And so that's essentially what it looked like. But when I looked at the mammography, you can see it had some tortuosity on the right eye, which is the bottom left picture. And then on the bottom right picture, she did have maybe 20-25% gland atrophy there. And so pressed on the glands, did have some cloudy secretions there. Any other tests going back to, what is that ocular surface evaluation? Considering or evaluating for nocturnal lag ophthalmos, so at least we could rule that out. Doing corneal sensitivity testing. In this case, for a patient with neuropathic corneal pain, you can have increased sensitivity on those patients, and so that can be documented. Causes of neuropathic corneal pain, whether it's trauma, previous infection, systemic disease, which is going to be important for those that may ever have this question come up, whether it's due to autoimmune conditions, depression, diabetes, or fibromyalgia. Those are the most common conditions associated with neuropathic corneal pain. So what is happening once again with neuropathic corneal pain? Well, it's abnormal firing. There's peripheral sensitization of the peripheral nociceptors within the cornea. And so it has lowered the threshold for any future response. And so that's why the patients have such a exaggerated response, is because of that abnormal firing. There's no universal criteria for the diagnosis. You can do the case history. There is a survey, the pain assessment survey, the ocular pain assessment survey, the OPAS. And so that can monitor whether or not, or where that patient is within symptoms, but also the symptom relief. Does the patient know what the trigger is? Is it when they're outdoors? Is there any, maybe when they drink wine or whatever it may be? How long has this been going on? What exacerbates it? What's worked? And for her, nothing's worked in this case. The symptoms, using everything, but no relief, but pain without stain. So everything looks good. And so this is where we do our anesthetic test. Is we put a drop of proparacaine in the eye and we wait a few minutes. And then we're asked the patient, how does it feel? If the pain goes away, then we know it's affecting the peripheral nerve endings. And so we know it's more ocular surface, and we're going to be more aggressive with the ocular surface. If they're still in pain after you do that, the pain may go down a little, let's say 50% less, but that means the patient has both a centralized component of the pain as well as a peripheral component of the pain. So we treat the surface, but we may need to treat, or we will need to treat that with co-manage that with a primary care provider or a pain specialist to help with that centralized nerve pain. And so if it's just painful and they get no relief, then we know that we do have to definitely find relief with pain management or their PCP. If you have access to a confocal microscopy, this is something that you can do. We had one, but it broke. So that hasn't been replaced yet, but you can take pictures here. This is from Scott Hosworth. Here you can see the microneuromas that are found within those corneal nerves that are pathognomonic of patients that do have neuropathic corneal pain. So if they have that, what are our treatments? Well, we can either regenerate the nerves, and so what's going to be able to do that, and what data shows that it can do that, or we reduce the inflammation that makes the nerve more sensitive. And so that's why whenever we're having that patient with neuropathic corneal pain, we're still using our anti-inflammatories. We're trying to optimize that ocular surface so there's less triggers that are affecting our patients that are leading to this pain. So whether it's the serum tears, the steroids, the amniotic membranes, neurostimulation, systemic therapies, or biologics, that's what we're going to go into here. And so autologous serum, we already briefly talked about that. For neurotrophic keratitis, typically it's going to be around 20%. As you increase the concentration going up to 50%, you're going to have more transforming growth factors, which actually help, don't help. They actually delay the epithelial healing. And so normally for neuropathic corneal pain, you're going to go 50%, but neurotrophic keratitis, you're going to go more with 20% because there's less of that transforming growth factor. I think the cost typically with this, I think someone told me maybe $100, $200 for about 3 months supply, but don't quote me on that. But I will start to get some use of it soon, and I'll share with you my personal experiences. But we know the benefits and pitfalls of autologous serum, preservative-free. They're not going to get an allergy because it's their own serum. It does improve symptoms, and that's been demonstrated in various studies, whether it's for dry eye, whether it's for neurotrophic keratitis or neuropathic corneal pain. Complications, no insurance coverage, blood draw, and we can see that. In regards to amniotic membranes, lots of different membranes that are out there. Try them both. Why? Because like my earlier case, one fell out, so another one would fall out if I used the ring. And so that's where I went with a dry membrane. Typically in our cornea clinic, we've had more success with the cryopreserved membranes. But I do, once again, recommend you do both because there are going to be times when you do need to do both. And so you'll see what's going to give you the best clinical results afterwards. And so pros and cons, you can read those here, the cryopreserved versus the dehydrated. But once again, try them both because they do work. And I showed that with that one case, that cataract case. That was fun last. I'm going to skip the insertion and removal, different ways to do it. And I'm happy to send you videos if you're interested on that. But looking at the membranes. And so here's a study. You're not going to find too many studies in regards to amniotic membranes because it's going to be not cheap to do that study. But typically, you're going to see more case reports and case series. But here's a study from Tom John. He's a cornea specialist out of Chicago. And so these are 20 patients with on maximal medical therapy, or were on maximal medical therapy. And they had severe dry eye disease. And so they kept half, so 10 patients on maximal medical therapy, saw the anti-inflammatories, plugs, omegas. And then the other half, they put a cryopreserved membrane in for 5 to 7 days. And so what I want to focus on is the pain score, because when we're talking about nerves, whether it's neurotrophic, neuropathic, the patients are in pain. And so the baseline was 7. The red is a control, so maximal therapy, things we're already doing. But with the cryopreserved membrane, the pain score went from a 7 to a 2 within a month. And at 3 months, it went down to about a 1. So how is it improving the pain? Well, if we take a look at through confocal microscopy, looking at the nerve density, the blue is the cryopreserved membrane. So looking at the density and sensitivity, you're going to see improvement at 1 month or in 3 months. So is this a cure? Not necessarily, but it is regenerating the nerve. And so something we need to think about whenever we have our patients that have these issues. The drops, we know that the drops do have anti-inflammatory properties as well. It does also have the growth factors. We've been seeing more videos or YouTubes about, hey, these drops, they're not regulated like the FDA. It's the approval process is different. The approval process is different for amniotic membranes, period. But we do know that we've had many patients over several years that have had great success with this. I have one patient in particular. She's had several membranes. She's had every single drop. She's had every thermal pulsation and IPL. And this is the only thing that's brought her relief. And so that's just one of many patients I've had. So to finish this off in the last few minutes here is, look at, what are the future insights when it comes to neuropathic corneal pain? So they have the centralized component. What can we do to help alleviate that pain for our patients? Whether it's going to be something such as Topamax, whether it's going to be analgesics such as naltrexone, which I'll show you a study on, Botox as well, gabapentin. And so this is something that we can utilize. And here's some recent studies looking at gabapentin used for dry eye disease and neuropathic ocular pain. All 3 of the studies are in regards to that. So take a screenshot of that. You can look up those studies. For the sake of time, we won't have time to go into those. But something that we can consider, depending on the state you live. This is something that you could prescribe. Here in Virginia, this is something that we can prescribe for our patients. And so it's used to suppress exaggerated pain and seizures. It reduces the release of glutamate. So you start with an early dose, 300 milligrams twice a day, and then within a week, you can build up to 4 times a day for those patients. From that patient, going back to this 29-year-old patient, if you recall, she was on nortriptyline. And so here's a study. This is from Tufts University. It's an off-label study looking at nortriptyline for patients with neuropathic corneal pain. Retrospective study, 54 patients with the centralized component of the pain. And so wanted to see the response to treatment using that ocular pain assessment survey. 30 of those 54 patients were included in the final efficacy analysis. 30 patients, 40% of those reported 50% or greater reduction in overall pain score. 19 out of 54 discontinued due to side effects mostly, which you can see being tired, dry mouth, constipated, nausea, whatever. But this is just something that when we're co-managing, if the primary care house, goes, hey, what are your thoughts? What can we give him or her? Then we know that nortriptyline may be an option for our patients. Mentioned low dose naltrexone, and so this is used for patients with opioid or alcohol dependency. And so low dose naltrexone is in a study below is effective and well tolerated for modulating symptoms of pain, patients with neuropathic corneal pain, because we know it's damage and disease of the nervous system that innervate the cornea. So in this study, it was a 4-week study. Patients were given 4.5 milligrams of naltrexone once a day, and it was given at bedtime. And what they found, it did decrease the ocular pain score by almost 50% of the patients in the study. The side effects, vivid dreams, well, they're taking it at night, so that'll be okay. Headaches and stomach aches were some of those side effects as well. What about Botox? If we recall, migraines can also be associated with patients that have a neuropathic corneal pain. And so this is a study, 90 patients that had lots of migraines and have failed at least 2 migraine drugs in the past. And so looking from 0 to 10 with supraphotophobia, and we know many of our patients are, and what they found is this did decrease, or did have patients have symptomatic improvement in the photophobia by almost 73%, about 29% improving the dry eye symptoms. We know that many times with ocular surface conditions, patients may have blepharospasms associated with this too. I'm totally going on a different tangent, but either way, you can use Botox for that too. And so doing the injections in the forehead, doing the orbicularis, the corrugator, the procerus muscles, and even at the traps and behind the ear and the bone, those are areas that would be injected within the for patients with neuropathic corneal pain and migraines, and so something that may benefit our patients as well. And so this was something that just came out just a couple of weeks ago, and so this is a investigational new drug application that was submitted to the FDA. So looking at OK-101 to treat dry eye disease. But the reason why I have this in here is if you see the 4th bullet, it is shown to produce anti-inflammatory neuropathic pain reducing activities in mouse models. And so the drug itself is contained within a lipid base to help maintain the contact time on the ocular surface. But this is something, there's lots of potential treatment options that we're going to have for our patients. And so in the neuropathic corneal pain, we want to take the holistic approach. It's not just the eyes. We mentioned depression, anxiety may be associated with patients with neuropathic corneal pain. And so is it the pain specialist that we need? Do we need a psychiatric or neurologic evaluation? Where does a primary care physician come in? And typically, just like we're the quarterbacks for the eyes, working through the primary care may be an optimal option for the patient to make sure someone's the quarterback of that care. And so going back to the first patient that we started with, the one that had the telangiectasia, the mild MP9, she did have the neuropathic corneal pain, but also dry eye. This is the one, once again, that was referred to me for punctal plugs and another opinion. She's the one that wanted new glasses but has unstable tears. She wanted to be on loteprednol long term, but had talked to her about the side effects. And so essentially what I did is I just put her on the anti-inflammatories. You saw her meibomian glands, and I recommended IPL because of the telangiectasia. When I bring her back, and so I should see her in a few weeks, likely I'm going to go to autologous serum will be my next step. But as I mentioned, we have amniotic membranes that we could use. We could, if it's a centralized component, we can refer it to primary or pain management or primary care. But in the end, whenever we're looking at the cornea, well, first, it's not in this lecture, well, kind of in this lecture. If it doesn't make sense, it's likely herpes related, but consider corneal sensitivity in any of those patients where you see the recalcitrant dry eye or significant staining. Aggressively treat the surface. You can see the impact on both neurotrophic and neuropathic corneas, but treat and follow, good patient care. We can modify treatment, but also helps improve compliance for our patients. And so thank you, Stephanie, and everybody here for allowing me to ramble on